Good afternoon, everyone. And at the outset, I'd like to thank the organizer, Dr. Sanjay, for inviting me. And my job is to tell you what's relatively new in lung cancer. Uh, Lung cancer has been moving pretty fast in last many years, and so I won't be able to accommodate all, but try to give you update what are those relevant data we have. Starting with lung cancer, the major cause of mortality, it remains today also. What has been the development and is it making some impact? And we all wanted to know what happens with SEER data. And now you started seeing in the SEER data and maybe the first time that yes, lung cancer mortality going down, which we have not seen in the past with the lung cancer. Looks like equal number of people getting diagnosed and equal number of people dying, which is stopped happening for lung cancer. Again, one good news and one bad news. This looks like primarily because of treatment what we give, various treatment which is developed. One bad news, screening has not picked up well. Screening is today in the best of the places. If you take United States, it remains around 8% of the people who who are eligible to go for screening. So that's a bad news. Now, another question which always we wanted to know, if you have a small lesion, how much surgery is enough? We always want to know, can we do smaller surgery which can make the life of the patient better? This was a randomized trial. There is another one before that, presented in World Lung Congress called Alliance Study, less than 2 centimeter lesion, peripheral one, and if you can do lobectomy versus far lesser surgery, which we always prefer. And these were the treatment characteristics, and most important is this one. Looks like, yes, bang on the top of each other. So it looks like if less than 2 centimeter peripheral lesion, if you do lesser surgery, then lobectomy, then looks like outcome of the patients are similar. Same for OS. And what I was looking for in this data, what happens to the local failure? Because that was the previous data from Japan, which suggested that local failure is higher in a lesser surgery as compared to lobectomy. It appears in this data that loco-regional failure is also similar. Again, reassuring that you can do lesser surgery. Comparing that with the Japanese data, looks like outcome is, overall survival is similar, but local failure being more, not sure why we have these differences, but having said that, more reassuring data that lesser surgery is good enough. Another question which we keep hearing, keep debating, keep discussing, many people would be coming and talking about liquid biopsy in lung cancer. Does it help? Yes, we know it does help in diagnosing the patient and giving treatment. What we were looking for, how it helps the overall treatment paradigm. And we know that targeted therapy, if you give it to improve survival, and this is for liquid biopsy. So what someone did, Dr. Natasha from Canada, they looked for if you include liquid biopsy, and what do we do include at the baseline, all patient, all comer, and in other group you don't. Do you benefit in a patient anyway? What they found that you have around 15% patients where you will find mutations, where you can target it, where you will not find in tissue biopsy. So there is a merit to it that they will have a treatment which will be less toxic and more effective and also less costly, especially in the context of Canada. My feeling is that that may be true for our patient also. But the only catch is the liquid biopsy availability, easily being available in our population is a challenge. But again, looks like you will keep hearing this space more and more as the time goes by, liquid biopsy getting more and more integrated in our treatment paradigm. Adjuvant treatment, we had the discussion and some of the data will be a bit of a repetition. We know chemotherapy works. What we have been looking for, targeted therapy, there is some data, there is some activity for the older drugs. If you add the newer drug for EGFR mutation positive patient, yes, it works. Not only it works, it doubles the disease control rate what you have. So if you have the PFS of around 40%, it becomes around 80% if you give this drug. OS data is not available, but if disease control is good enough for you, please, you can use it. Do we have, this is subgroup analysis, and where it primarily works, apart from local control, is the CNS relapse, which we are concerned about, because CNS relapse, if you have, you really don't have a good treatment in this setting. What's the data regarding adjuvant immunotherapy? And this is the Empower, what we call 010 study, a famous one. What it showed that if you have stage 2 and further stage disease, and if you have done surgery and the tumor is PD-L1 positive, there is an absolute improvement in more than 10% in disease control rate in these patients. Again, highlighting that if you have PD-L1 positive patient, higher stage disease, if they are resected, and then if you have not given immunotherapy in neoadjuvant setting, yes, if you give immunotherapy in this setting, it controls the disease far better. There is one contradicting result, which was this one. If you use pembrolizumab, looks like it has a similar result, except one of the issue was that the DFS overall, the hazard ratio was 0.76. If you take PD-L1 more than 50%, hazard ratio is 0.82. That is usually doesn't happen in immunotherapy. So that is something to ponder about. Does it the benefit remains disease and the specific immunotherapy is specific, or is it for any immunotherapy? I can't say for sure that I can say pembrolizumab to be used in this setting. Most likely we need to be using atezolizumab in case if we have to use it. Does this adjuvant concept, why we talk about again and again? Because when it has been tried in many settings, it looks like it works. Again, this was a specific study, chemoradiation, then you give adjuvant immunotherapy, it looks like again it works. If you see the PFS data, 19% at 5 years as compared to 30% plus, doubling of usually PFS doesn't happen with most of the treatment available, highlighting that adjuvant immunotherapy again works. So if the concept works, you keep talking about that it works in many settings. And that's the reason in resected patient also, we think that yes, there is a merit for adjuvant therapy. For overall survival at 5 years, there was improvement in overall survival of around 10%. Remember, in the standard arm, the patient did receive subsequent immunotherapy. If that would have been removed, the data of 30% at 5 years would not have been there with chemoradiation. Remove 10% below that, then you know the real value of immunotherapy in adjuvant setting after chemoradiation in these group of patients. Data for neoadjuvant immunotherapy in lung cancer, we did have a discussion. It was talked about, Checkmate 816 study. Pathological response definitely increases. We have not seen this kind of data. I can't say I have used it much, hardly 2 patients, but you have 1/4 of the patient where the tumor vanishes in the pathology. That has not happened in lung cancer. Looks very promising. Event-free survival, again, promising. You have almost 16 to 17% difference in the event-free survival in the standard arm versus other arm. In that specific group of patients, then it looks, there is something which is important here. We had a discussion regarding, do you have something more substantiating what we do in neoadjuvant setting, what we heard earlier. This is a Nadeem study, got presented in World Lung Congress, and in stage 3 patient, in this group of patient, OS was not the primary endpoint, but if you see the data, absolute improvement in overall survival of around 20%. And this is what I say, that when you start seeing that multiple studies in multiple ways used around surgery, around radiotherapy, and improving event-free survival and overall survival, you know that this news is the real news. That's not a fake news. And that's the reason one needs to start thinking about where and how you're going to use it. So again, we are waiting for all 816 study, and hopefully that overall survival data, that may confirm it or refute it. But in the meantime, there is a reason to use it. Now, some data regarding the long-term outcome, because we all want to know if you have TKI works, what happens at 5 years? We know at median survival of 2 years or median survival of 20 months. What happens at 5 years, 10 years? How these patients do? Do we have data for it? And we know all these mutations. If we see, you start having multiple 5-year survival data with mutation-positive lung cancer patient. This is for EGFR mutation-positive patient, around 5-year survival of around 40%, and now at least you have 4 randomized trial, where you have a 5-year survival of 40 to 50% in non-small cell lung cancer in stage 4 patients, which we have not seen in the past. Do we have only one? No, you have many other. This is for ALK mutation-positive patient. The 5-year survival of around 60% plus if you are using ALK inhibitor in these group of patients. Again, I remind the audience, this is a stage 4 patients. We used to have the median survival of 8 months. And what we are talking about, 5-year survival of 60%. Reminding that, no, we are not talking about stage 3 post-op patient. If you do stage 3 post-op patient, so George operates it, 5-year survival of 20% or 25%. So remember, context starts changing the way the treatment starts working in this setting. Do we have some more? If you have a RET mutation positive patient, again, you do have a median survival around 40 months. That is a 5-year survival of around 40% here again. In anti-RK mutation, again, 5-year survival of around 40% plus. This is for MET. This is similar data for KRAS, not so promising. Do we have some long-term data for immunotherapy? Yes, we have a long-term data for immunotherapy. If you used immunotherapy in more than 50% PD-L1 positive patient, and it appears the 5-year survival of 30%. So 1/3 patient start surviving, which used to be around 5%. Again here, the standard arm is fallacious because standard arm here in overall survival, they receive immunotherapy in second-line setting. Go back to non-immunotherapy trial data, the 5-year survival is 5%. And then we realize how it is making difference in the outcome of these patients. If the patient lives after immunotherapy of around 2 years, then by and large looks like they start living subsequently. They usually don't fail. But the catch is that only 20% of them, they go beyond 2 years. Majority of them, they fail earlier. So that's another part of it, suggesting that, yes, glass is half full. What we are moving forward now, we have started learning that what happens to these very effective treatment. What are the mechanism resistance which may help in getting far better treatment in this setting. But what it also tells us, all the treatment which I talked about, which are very good, they are effective, but also majority of these patients, they keep failing, and that's the reason we need to learn what is the mechanism of resistance in this group of patients. This is the data for EGFR mutation positive patient for osimertinib, and these are the mutation mechanism for various TKIs in ALK positive patient. Why it is important? Because this will tell us what kind of drug one needs to find out to see that it is effective in this specific setting. So in conclusion, overall, yes, there has been a significant change in outcome and the treatment development in non-small cell lung cancer patient. Again, I always say this is half full, and this I learned while counseling a patient of 26-year-old non-small cell lung cancer patient, stage 4 EGFR mutation positive, and I was counseling all gung-ho that this is good, you have EGFR mutation positive patient, you will be doing well. And then I said average survival of 5 years, and he kept looking on my face, doctor, I'm just entered my engineering, and we are talking about 5 years. And yes, that was grounding us that yes, as much development we have had in lung cancer patients, which are very significant, also glass is half full. You have a significant proportion of patients who keeps relapsing and keeps dying in lung cancer. And today also, the biggest number of patients in cancer dies because of lung cancer. So that's the sobering part of the development in lung cancer. Thank you so much. We'll be happy to take if there is any question.